Good evening, and welcome to the second webinar of the Musculoskeletal Tumor Society's Advocacy Taskforce. Tonight, we'll be talking about the regulatory side of advocacy. I'm Kelly Homlar, co-chair of the task force. Before we get started, I do want to go over some housekeeping items. Please know that all participants are muted. For technical assistance, you can reference the Help tab at any time. If you do experience technical difficulties, it's best to close all browsers and log back in the same way that you did the first time. We're recording this webinar, and we will provide a link to the recording within the week. This webinar is scheduled for 1 hour, and time has been reserved for questions at the end. So please type your questions in the chat. We will be monitoring the chat throughout the session. Thank you once again for joining, and I will now turn it over to Susan McDowell to introduce our speakers for tonight.
Good evening, everyone. We have two wonderful speakers. Dr. Adam Levin is an associate professor of orthopedic surgery and oncology at Johns Hopkins University and serves as vice chair for clinical operations in the Department of Orthopedic Surgery, where he leads initiatives in clinical optimization, workflow efficiency, and revenue integrity. He also serves on the Johns Hopkins Medicine Compliance Committee, overseeing system-wide coding and billing integrity. Nationally, Dr. Levin is chair of our MSTS Practice Management Committee. He serves on the AAOS Coding, Coverage, and Reimbursement Committee, as well as the AMA CPT Advisory Board, where he represents the American Orthopaedic Association. Dr. Levin has been a national leader in orthopedic coding and reimbursement education. Our other presenter is Jordan Heyman. She's the Senior Director of Policy and Regulatory Affairs in the AAOS Office of Government Relations, where she leads the Academy's federal regulatory, legislative, coding, and reimbursement portfolio on behalf of orthopedic surgeons and their patients. She brings more than a decade of national health policy experience, including leadership roles at the National Association of Manufacturers and the Blue Cross Blue Shield Association, as well as prior service as a health policy advisor to members of the U.S. House Ways and Means Committee. She holds an MBA from Johns Hopkins University. Turn it over to Adam.
Great, thanks so much, and thanks for the warm introduction. We're going to give kind of a broad level overview of some of the considerations regarding regulatory advocacy and try to give a broad landscape. We're going to try not to get into too much of the weeds, though there are a little bit of the weeds that we need to at least show you where they are so you can understand it. So we'll get things going. So first things first, how are services covered and how are payments determined? And a lot of that really depends upon what you're asking about, what type of service you're talking about, and where that service is being performed. Most of the services that we do in terms of our professional fees or even our outpatient fees are going to be determined by CPT. There are some devices and DME that start coming into things like HCPCS, and then the hospital inpatient codes. Those are actually determined by a totally different set, ICD-10, which we'll get into just in a little bit. So most people don't really know about HCPCS unless they're really into the departmental or practice finances. HCPCS is this healthcare common procedural coding system. It's administered by CMS. The level 1 HCPCS codes really are the same as CPT for the most part. Those level 2 codes, those help dictate things like DME and devices, particularly some devices when they're done in an outpatient or an ASC environment. Next slide. Now, the ICD-10 is the International Classification of Diseases 10th revision. There is already an 11th revision, though that's not active really in the United States, but globally it is used and has been for a couple of years. Spoiler alert, over the next couple years, we will start hearing more and more about transition to ICD-11, but I have not heard a specific transition date settled yet. ICD-10 is administered by CMS and the CDC. There's two main parts. We're mostly familiar with this ICD-10 CM, which is the clinical module. Those are all the diagnosis codes that we're used to and we've been tortured with for years. But there's also an entirely different set called the procedure coding system, or PCS codes. And the PCS codes is really how hospital inpatient procedures and services get paid. And they're informed by CPT, but they also help inform things like diagnosis-related groups or DRGs, which are, yeah, now we're getting too far into the weeds of stuff. But just know that when we talk about ICD-10, we're typically talking about the clinical module, that's the diagnosis codes, but your hospital coders, they may be talking about PCS codes, which is how the hospital gets paid for our services when we do them inpatient. Next slide. So, when we are talking about our professional fees, we're really talking about CPT. And this is current procedural terminology. And this really, it's a coding system that lists codes and descriptors for reporting pretty much any service, any evaluation of management, any procedure that's going to be performed by any of us. It's maintained by the AMA, and really is, while the AMA oversees it, is really informed by innumerable national medical societies that make up the AMA House of Delegates. So it's overseen by the CPT editorial panel, and they're responsible for maintaining the entire CPT code set. And these are through either new codes or updating or modifying codes over the course of time. I am an advisor to the CPT, one of the advisors for the House of Orthopaedics. There are 18 standing members. And one of those currently is an orthopedic surgeon and a member of the AAOS. And there has been at least one member of the AAOS on the CPT editorial panel for decades. The CPT, when you hear us talking about new codes, generally when we think about CPT, we're talking about Category 1 codes. These are all the ones that have a value or an RVU, which we're going to get into. Category 1 codes really are describing procedures that are standard, normal practice type of stuff. They're consistent with current and contemporary medical practice. They are being performed. They are being performed at clinically appropriate volumes by lots of physicians across multiple locations with demonstrated efficacy. So essentially, the criteria to get a new Category 1 code would be something that has widespread use and has robust clinical literature, level 1, or maybe a couple of level 2 studies. There are some exceptions to that, but for the most part, we're talking about when we can't get a level 1 code, it's because we don't have either widespread use or abundant high-level medical literature to support the use of that code. And that's where, in things like orthopedic oncology, sometimes we have to rely on exceptions to that rule in order to get things over the hurdle. Now, there's also a whole set of Category 3 codes. These are really temporary tracking codes for new and emerging technologies and services. They typically sunset after 5 years, though sometimes we can petition to keep these Category 3 codes. There are no RVU values for them, so you would basically be carrier priced for any of those services, but they are subject to being considered experimental because they technically are meant to have new and emerging services that don't yet have widespread use and abundant medical literature to support. Next slide. So once you have a code, it then goes to the RUC. The RUC is the Relative Value Scale Update Committee. The RUC is really a multi-specialty committee that provides the entire house of medicine with a really powerful voice in describing what goes into, what resources, time, energy, skill is necessary to perform these services. And so it's informed by the national medical societies, those that make up the House of Delegates, as well as allied health professional societies and the CMS, but it is run by the AMA. The RUC has 32 seats. While it says here that one is for the AAOS and there is an AAOS member, as I'm reading it now, I'm realizing that there's actually a hand surgeon from the Hand Society that is also a member of the AAOS, though not representing the AAOS on the RUC. So technically, we have two AAOS members that are at the table on the RUC. There are about 125 specialty societies that are represented in the AMA House of Delegates, and anyone that has a House of Delegate representative has the option of appointing a RUC advisor or a CPT advisor to help advise each of those governing bodies. And the RUC advisors help represent the dominant society for any code that is up for revaluation. Next slide. So the RUC helps determine what the relative value units are. So they help recommend for either anything with a Category 1 code is going to have an RVU valuation. The RVUs are determined by three main factors. We're most familiar with the work RVUs, and that is based off the time, the effort, the skill, the stress to perform a service. And when we talk about the service, we're not just talking about it, we're talking about the entire global period. So E&M services don't have a global period, or a 0-day global, but many of our procedural codes have 90-day globals. So when you're considering the time, effort, skill, you're also talking about the value of all of those E&M encounters that happen over that 90-day period. You also take into account your practice expense. What is the overhead for running a practice to be able to perform that expense, that procedure? This is more impacting evaluation of management codes and things that are done in the office, whereas if it's done in a hospital or facility location, practice expense is typically taken out because you have a separate facility-based fee for that. And then there's the malpractice risk. So malpractice RVUs. Next slide. So the RUC then starts with identifying a service. So this could either be a new CPT code, or sometimes codes are recognized as being potentially misvalued, so they come back to the RUC for resurvey. You need to have at least 30 practicing clinicians for any surveyed code. So it then goes out from a RUC survey by the dominant specialty for that is supposed to do the survey. Sometimes the dominant specialty changes for certain procedures, and therefore someone else, they need to resurvey it using a different specialty as the surveying body. Once you have the survey results, the dominant specialty societies, RUC advisors, make a presentation to the RUC to try to get the best valuation. Then the RUC makes their recommendation, and then CMS can decide whether they like that recommendation or whether they're going to overrule it. About 80% of the time, the CMS will agree with the RUC's recommendation, though that means that 20% of the time they end up changing it, and rarely do they increase the valuation, though occasionally they do. And then every year, the RVU schedule from CMS gets published in the Medicare Physician Fee Schedule every July. And that is pretty much what any other payer ends up taking as the RVUs. Next slide. And then so this physician work, the practice expense, the malpractice, all those RVUs get summed up into a total RVU, and that gets multiplied by a conversion factor. So for Medicare fee-for-service reimbursement, that is published in the final rule for the physician fee schedule, and those are all adjusted by this geographic practice cost index, or the GPCI, so that higher expense areas get a little bit of a cost adjustment upwards. Now that conversion factor, generally we would say, well, we just want everything to have high RVU values, but the truth is that Medicare Part B is capped on the national expenses that they can have. So there's a budget neutrality formula. So essentially, the more RVUs that are out there across all of medicine, well, the more RVUs that are out there, the lower the conversion factor because the total budget ends up being the same. So the more things that are towards the non-procedural list, that actually dilutes down what we get at the end of the day as procedural specialists. So next slide. There is always a lot of intrigue and mystery around the RUC process. Every year, the New York Times will publish an article talking about a cabal of surgeons and physicians that divvy up all of Medicare's money. And while it's a little bit different from that, some of the criticisms have been that primary care is underrepresented. Yet 21 of the 29 voting members of the RUC are primary care or primary care adjacent specialties. These are the cognitive specialists. The myths are that the RVUs are biased towards overvaluing procedures, though frankly, they have a whole project towards potentially misvalued codes, which are almost always procedural codes. They say that it's opaque, but actually the meetings are open and published as to, and there's valuation, the whole, everything is open to all specialties across the board. And everyone says that the specialty collected surveys are unreliable, though CMS has yet to provide any better alternative that works any better. And frankly, the data seems to suggest that despite the potential for conflict of interest, the process works quite well, especially since they typically do this at the 25th percentile of survey respondents as where they end up valuing things. So in the end, it's a pretty fair and open process overall. So we're going to go on to the next slide. I'm going to hand it over to Jordan to pick up.
Great. Thanks so much, Dr. Levin, for your expertise on the CPT and RUC process. There are some more tidbits about RVUs, about the rules scattered through the rest of the presentation. So if you feel like some stuff kind of came out of thin air, I'm probably going to be providing more detail as we move forward. So AAOS advocacy has three major functions. Legislative, which I understand you all have already had a webinar on. That's educating members of Congress and getting bills passed. That's what you hear about primarily in the news every day, is what is happening in Congress. Regulatory is a little bit more mysterious, and that's what we're here to talk about tonight. And that is influencing the agencies that interpret the laws. So these agencies all fall under the umbrella of the executive branch. They're led by cabinet secretaries. They are the bureaucracy, they are the deep state, they are choose your word depending on your news source. But they are the experts behind the scenes who take what Congress puts into legislation and then makes it granular enough that it can actually be implemented and put into play on a national scale on the ground in the real world. And then political advocacy is tools to support our policy goals and help elect members of Congress who support increased access to musculoskeletal care. When we say political, we're referring to Orthopaedic or other political action committees of other organizations. So rules and laws have the same force, but they emerge through very different processes. So you're used to legislation, Schoolhouse Rock, I'm just a bill. That's the process of going through Congress. Regulations are a little bit different. So they can either be initiated by the agencies themselves with a tie back to legislation, or Congress can pass laws that directly tell the agencies to regulate. So regulations are introduced by federal agencies. They're available to the public for formal comment periods. They are also available to Congress to comment. Then they're published, and then they have the force of law. So it's a little bit different, but you end up in the same place, which is binding things. Here's another map of the rulemaking process specifically. So Congress passes legislation, and then the agency decides a rule is necessary, proposes the rule and solicits comments, reviews the comments and makes updates, submits to the Government Accountability Office and the Congressional Budget Office for final approval, then publishes in the Federal Register, and then you enter compliance, interpretation of review. So a lot of times when you hear about lawsuits, so the No Surprises Act is a great example. Congress passed the law. The agencies passed regulations. They got comments back. They finalized a rule. Texas Medical Association and others sued the agency, claiming that they misinterpreted the law that Congress wrote. The courts got involved. Some of those cases have been settled. There were multiple cases. Some are still going through the courts, but that is a very typical process of what happens with rulemaking. So most of the work we do centers on the Department of Health and Human Services and the regulations that come out of HHS and its sub-agencies, primarily CMS, which is down here. Sometimes you will hear about the tri-agencies. That is, for example, the No Surprises Act is HHS, the Department of Treasury, and the Department of Labor, because you're dealing with employer-sponsored insurance, so you touch all three of those departments. In the Medicare space, you're only working within CMS. There are some other sub-agencies in here that we'll deal with occasionally. Sometimes the Office for Civil Rights will put some stuff out. Strategic Preparedness and Response, FDA, CDC, NIH, but we are primarily at CMS. And then this is just an overview, another chart to show you a different version of the stack of what happens in the rulemaking process. So as you can see, there's a lot of steps, there's a lot of ways to describe it. But since these are up on screen, you all can go through them later and kind of pick what makes the most sense to you. So Dr. Levin talked about the physician fee schedule. We're going to go into a little bit more depth now. And this is the regulation that most directly impacts your practices every day. This is what sets payments in the Medicare system. This is where codes become payable. And you hear regularly that a lot of commercial insurers will follow Medicare in some way, shape, or form. So the Medicare payment rates and policies really drive what happens across the rest of the market for all of your patients. So the fee schedule pays physicians for your professional services, certain items and services, lab tests, and radiology. It is all considered Medicare Part B, which is outpatient and physician services. As Dr. Levin explained, each service is assigned a number of RVUs. They are multiplied by the conversion factor, and that conversion factor changes each year. It is important to note that the conversion factor is not tied to any measure of inflation. This is very unique to the physician fee schedule. The hospital payment systems, both inpatient and outpatient, are tied to a market basket, which is a measure of inflation of medical goods and services. So they get an automatic adjustment every year, whereas we do not. And that is how you end up with this chart here showing medical cost inflation versus physician updates when you account for inflation. And it is very dire. And we are on the Hill and at the agencies fighting this fight every single day. You'll also see below here the timeline for the rulemaking process. So the proposal comes out around mid-July. We then get exactly 60 days to comment, which puts us usually to the beginning and middle of September. And then the final rule has to be released by November 1st, and it gets implemented exactly 2 months later on January 1st. So conversion factor updates. You have the baseline where as of this year, qualifying APM participants get a 0.75% boost, and everyone else, which is most of you, get 0.25%. Dr. Levin also talked about budget neutrality. The way that the rule shook out this year, that is a 0.49% increase. And then Congress tried to help us by giving a 2.5% bump to the conversion factor in 2026 in the Reconciliation Bill, also known as the One Big Beautiful Bill Act, also known as the Working Families Tax Cut Act, that passed last July. So here's the actual conversion factors. Oh, I forgot to put the dollar amounts. I'm so sorry. The boost for most of you this year was 3.26%, and for qualifying MP and the APM providers, it was about 3.77%. The conversion factors are somewhere around the $33 and change range. And I'm so sorry I forgot to put those numbers in, but we can definitely follow up if you want the dollar amount. We tend to talk in percentages more just because the dollars change every year, so the percentages tend to be a better way to gauge what's going on year over year. So there were two major policies in the rule this year that had a dramatic impact on proceduralists. I'm just checking my time here. One is the across-the-board efficiency adjustment for most non-time-based codes. So this excludes the E&M codes, but includes pretty much everything else that you all do. This is a 2.5% cut to the work RVUs. So that's one of the three categories that Dr. Levin talked about. The cut is based on MEI, the Medicare Economic Index, which is a measure of inflation and productivity, even though the conversion factor is not tied to MEI. Oh, shoot. Sorry, guys. CMS intends to make an efficiency adjustment every 3 years in perpetuity. So the cuts will compound and payments are just going to get smaller and smaller over time. AAOS strongly disagrees with the entire premise of the efficiency adjustment, and there's a great study in the Journal of American College of Surgeons completely refuting this notion that codes have gotten more efficient over time. In fact, they have found that time has stayed the same. Even so, patient outcomes have not gotten worse, death rates have not gotten worse, but nothing's gotten more efficient either. And they looked, oh my God, I'm so sorry, y'all. So there is a bill in Congress that's on the legislative side, so we're not going to talk about it a ton. But it was introduced earlier this year with significant help from Dr. Michael Parks, our new first vice president, to get a Democratic co-sponsor. So we had a bipartisan bill, and we're pushing really hard for co-sponsors in the hopes that that will help pressure the administration to make some changes, to make the policy more grounded in reality and substance and facts. There's also, so we talked about practice expense RVUs. Those are split into direct and indirect. And in an attempt to get at issues of consolidation and double payment, CMS implemented a policy to cut 50% of the indirect PERVUs for services performed in a hospital or an ASC. Those RVUs are then being redistributed to the office setting. So CMS, let me see if I can mute this. Okay, forget it. I'm sorry, guys. So CMS has argued that the current system overpays facility-based physicians. They were trying to get at employed physicians, is what we think. But they forgot or couldn't figure out how to account for the fact that many physicians in private practice still perform procedures in facilities, because many, in our case, orthopedic procedures cannot and will never be done in an office because they are major surgeries with anesthesia, complications, et cetera, et cetera. So even procedures right now that could never be done in an office setting are still taking this hit when they're performed in appropriate facility settings. We have expressed concerns about this policy for that reason, but we do also acknowledge that it will have different impacts based on subspecialty. So some of our subspecialists, like our hand specialists, our foot and ankle specialists, do more procedures in the office setting. So they could see a very different impact than our specialists who do total joints, for example, where those procedures are always done in facilities. So we're still trying to figure out exactly the impacts, but from the data we've seen so far from CMS, the impact will be greater and more harmful on the whole to more orthopedic surgeons than it will help. So we're trying to thread this needle between not hurting anyone, but also making clear that this policy does not do what was intended and is not a fair way to get at this issue of employed physicians, consolidation and double payment. So here's the combined impacts of the two policies. So the 2.5% efficiency adjustment and the indirect PERVU shifts. So we are showing specific codes here because you can see that the impacts are very different based on the code in play. These numbers are slightly off because they were done with the conversion factors from the proposed rule, and they did change ever so slightly to the final rule, but you get the gist, and that's what's important here. You can also see why we have some splits between our subspecialists because there are some procedures that can be done in an office that are going to be seeing these really big bumps. And then the E&Ms also see a big bump if they're done in the office. I'm going to try and speed up a little bit here to leave time for y'all to ask questions. The outpatient system, so the outpatient prospective payment system and ambulatory surgery center payment system. This is also a calendar year rule, so it's the same timeline as the fee schedule. The big changes this year were that the inpatient only list was eliminated. So this was a list of services. It was created when this outpatient payment system was created around 2000. And at the time, they kind of guessed at like what procedures should only be done inpatient versus which procedures could be paid outpatient. CMS decided to eliminate that list in its entirety over 3 years, starting with all of the musculoskeletal codes. In conjunction, they also removed criteria around the ASC covered procedures list in order to expand the procedures that can be done in an ASC. So they took 276 procedures just based on the new criteria across specialties, and then pretty much all of the MSK codes that came off of the inpatient only list also went directly onto the ASC list. So as part of this reshuffling, when the codes came off the inpatient only list, they had to be placed into the outpatient payment system for the first time. And that is called ambulatory payment classification system. So I'm not going to go into a ton of detail, but the short of it is that we did a big project through the Coding Coverage and Reimbursement Committee to have our expert physicians, including Dr. Levin, look at where all these new codes were placed to determine if some of them should be reevaluated because they were either placed in a level that was too low, which was typically the case, they should be paid higher, or sometimes they were placed higher than they should have been, in our opinion. So we sent a letter to CMS asking them to reevaluate. And this is just a really great example of some of the work AAOS does behind the scenes. It's very, very, very in the weeds, but really makes a huge difference to your day-to-day practices and how you all get paid when you do procedures in facilities. Inpatient prospective payment system. We're not going to spend a ton of time on this. The big differences here are that this is a fiscal year rule. The federal fiscal year runs from October 1st to September 30th. So these get proposed in April. Then you have a 60-day comment period, and then the comments are due in June, and the final rule is released in August. So it's a different timeline than what you all are more used to seeing with the fee schedule. The team model, which some of you may know about because some of your hospitals are probably subject to it, is part of the inpatient rule because almost all of the procedures in that model are inpatient, except for the lower extremity joint replacements, which are also outpatient. So that is where this could come into play for you all. AAOS also worked closely on updates to this quality measure, which will go into effect as we speak. Again, I'm not going to spend a ton of time here, but this is just a quick overview of how payment works in the inpatient system. So it's done, Dr. Levin mentioned DRGs, diagnosis-related groups. That's how the payment system works. It's very, very different than on the outpatient and the physician professional services side. But I just wanted to throw this up here for you all to have a very basic understanding. And when you watch the recording, you can pause and read this if you're curious. But I'm not going to spend a lot of time here because you all will never be dealing with this directly. This is what your facilities deal with. But I just wanted to throw it up to show you how very different the different settings work. Because that's a huge part of the regulatory process is the nitty-gritty and the complicated and the technical. The Medicare Advantage technical rule is another one that AAOS is starting to get more involved with. So this is the rule that CMS releases to govern Medicare Advantage plans, which combine parts A and B, and so inpatient and outpatient, and often throw in the drug plans as well, Part D. We submitted formal comments back in January, and this was our first activity as part of the new AAOS MSTS collaboration on sarcoma, which I'm going to talk about a little bit later. This was our regulatory play to ask CMS to address narrow networks in the Medicare Advantage space, which we do think are becoming an impediment to you all being able to see your patients. CMS always does a little bit on networks. They didn't talk about narrow networks specifically in the rule, but we get to talk about whatever we want, as long as we can kind of tangentially tie it in. So we took this as an opportunity to start seeding the ground. We also supported improved prior authorization and guardrails around artificial intelligence, two other topics that CMS did not really raise, but that we felt were really important to speak on. One of the big keys with the technical rule this year that we find very disheartening is that CMS barely regulated. They went in with an extremely light touch and very much signaled that they do not want to be heavy-handed, that they want to give the plans maximum flexibility, and that they are trusting the plans to make changes that they have agreed to through informal press conferences, but then are not regulating, i.e., putting the force of law behind having to make changes. Then the agency turned around. There's a separate rule governing MA, the rate notice, which sets the payment rates and the benchmarks and all of that. In that rate notice, they basically didn't give the MA plans any boost this year to their payments. I think it was about 0.05%, which is a huge slap in the face to the plans. And they also addressed the problem of upcoding, which the plans hate as well. So the administration sent very mixed signals this cycle. And we will see what ends up in those two final rules in the coming weeks. But it's very interesting and definitely makes it harder for us to kind of figure out how to work on the reg side to address the sarcoma issues, both narrow networks and gap exceptions, because we're struggling to figure out where the administration's head is at and what they may be amenable to. We are working through it as we develop our plan and flesh things out more, but I wanted to kind of go through that so y'all understand kind of the weirdness that's going on right now and how that impacts the way we think about things in order to get across the finish line. I'm also going to quickly go through some of the value-based care models that are coming out of the Center for Medicare and Medicaid Innovation, which is part of the Center for Medicare and Medicaid Services. So the WISER model is the one we've probably been working on the most. This is implementing AI and machine learning based prior authorization for about 18 service categories in fee-for-service Medicare. There's not much prior auth in fee-for-service Medicare right now. It's very legally tenuous, but that's why this is being done through the Innovation Center. It's being tested in 6 states. Each state has a different vendor. And from what we've heard so far, the experiences seem to be differing fairly significantly based on the state you're in and the vendor you're working with. But so far, we're hearing issues around educating providers, both facility and individual physicians, about their obligations. We're hearing some states are having issues with their portals. But this only went into effect on January 1. So we're thinking as it rolls out and as people get more familiar with its existence and start seeing their claims going through these weird processes, that we'll start getting more feedback as well and a better idea of what's happening and what needs to be fixed. AAOS has been working with a couple other surgical specialties to really try and be constructive and shape this in ways that are beneficial to physicians. One of those is a gold carding program for physicians that consistently get their prior auths approved. Generally, it's about a 90% approval rate. CMS has promised that they will implement a gold card program in the second half of 2026, and we are eagerly awaiting more details from them on what that might look like. The access model is another one that just came out at the end of last year. This is trying to test outcome aligned payments for technology enabled prevention and management in chronic conditions. So, musculoskeletal pain is one of the categories. The payments for referring physicians who help manage patients in the model is only about $180 per patient per year, which is a very low number. That is different, though, from the outcome aligned payments that will go to the access participants themselves. In many cases, those access participants are actually the tech companies that produce and deploy the technologies that the patients will be using. Those companies have to have an MD or a DO as a medical director. So we are still monitoring this closely to see how it could impact orthopedic surgeons, how it may be useful to your patients in your practices, or how it may not be, because the quality measures are pretty ambiguous and the payment rate for referrals is so low. There's also some issues around exemptions and overlap. So we're working through all of that now, but we'll be continuing to communicate about this model. The other two, so we talked about team a little bit already. The other is the ambulatory specialty model, which is trying to test if quality of care for low back pain is improved by holding individual specialists accountable for quality, cost, and collaboration with primary care. About 950 orthopedic surgeons who are in the spine space will be mandated to participate starting on January 1st. We are paying close attention to this model because we do think that CMS may try and expand it out to other body parts. Well, I don't know why that's there. But it doesn't impact you all right now because of the way the model is set up versus the work that you all do on a day-to-day basis. This is a quick case study. I'm not going to run through this in a lot of detail, but this is just related to registries and how qualified clinical data registries access CMS data in order to be able to operate. So legislation, the macro legislation in 2016 established mandatory provisions that registries get access to claims data. When those regulations were, or when the legislation was turned into regulation, we feel that the regulations did not adequately follow what the legislation intended. And while they provided access, they made it very, very difficult. So we worked for about 8 years to try and change this to make that data more affordable and accessible to registries. Then in 2024, CMS issued a request for information on this topic, which is how they informally gather information in order to turn it into regulations. Then in 2026, they delayed a system that we disagreed with and agreed to work with stakeholders to continue to try to improve the process. So this is just an example of how long it sometimes takes in the regulatory space, how rocky a road it is, and how niche the issues are. But through persistence and really data-driven persuasive advocacy, we are able to make a difference every day. Sometimes it doesn't feel like it. Sometimes it's a very long road, but this is what we're doing in the background while the Hill is doing their thing. Real quick, I wanted to just talk a little bit about our partnership with you all. As I said, because of the weirdness on the regulatory side, We are thinking that more of this is going to be on the legislative Hill-focused side. Right now, we're still doing fact-finding meetings with the American Cancer Society and rare disease groups that are more frequently in this space to see what they've been doing and what they think is achievable and how to get there. We've already talked to you all about a small fly-in that we're going to do with your members in July for Sarcoma Awareness Month. And then we'll be using our Action Center to collect patient stories. I know Dr. Homlar has been doing that as well. And those have been incredibly helpful to shaping our plan. We'll be highlighting those stories on social and also using them in our advocacy at the federal and state levels, depending on what we think is the best path forward. We're also going to be putting together a toolkit for you all. We've been told that other specialties have done this and been really successful in helping their members. So we'll have sample letters to appeal insurance denials. We'll have guidance on filing appeals as emergencies rather than standard, which rushes your time frame to get answers. And then we'll also have instructions on how to file complaints with your state insurance commissioners. Because they are often understaffed and overworked, but if they start getting a deluge of complaints about the same thing, it tends to spur action. So that is another course we can take to try to move the ball forward. How can you get involved? Lots of ways. This is my email address. Please reach out to me, to Dr. Homlar, Dr. Levin, Dr. McDowell. We can all get you to the right place. And that right place depends on who you are and what you want to do and how much time you want to spend doing it. So there are things you can do that are as simple as signing up for our Advocacy Now newsletter, and then that will sometimes take you to grassroots action alerts on topics that are really timely, like the efficiency adjustment, like whatever we decide to do on the Hill around sarcoma and gap exceptions and narrow networks. And really, those are set up so you click like 3 buttons and you contact your member of Congress. Very low intensity, very low effort. At the highest end of the effort scale is coming to DC for a fly-in and spending a day or two on the Hill talking to your legislators. You can also do that at the state level, which, depending on your state, may or may not be less of a travel and time commitments. And then you can also donate to the Orthopaedic, which is this slide. Those dollars go to support bipartisan, so both Democrats and Republicans at about equal measure. I think last cycle we were about 55-45, but that is as far of a range as we get. House and Senate, we elected 4 new doctors to Congress, 3 Democrats and 1 Republican, and really build champions so that when we have asks, we know who to go to. And it's a way to get a hearing. It never guarantees an outcome. The two are not directly tied together, but it gives us more options to talk to people, and to talk to the right people. So the PAC is a really important tool that we use to make sure that your voices are heard, and also to make sure that our voices as organized medicine are heard as loudly as our arch nemesis, the trial attorneys, for example, who have an $8 million PAC. So it is necessary to get in the door. But what you all do every day, building your knowledge, building your skills, building your relationships, and talking to your members, that's what ultimately gets us the results. So if you have any questions about any of this in the future, I'm going to stop sharing. Questions now, questions later, please reach out to us. We were always happy to help. And with that, I'll turn it back to Doctors McDowell and Homlar.
Great. Thank you, Jordan. Thank you, Adam, for this great overview for everyone. And thanks to everyone for staying online for this webinar. We welcome any questions via the Q&A function in the chat. I have a really easy, simple question, which is we got a great high level overview from both Jordan and Adam today. Are there any resources that you are aware of, podcasts or educational resources for people that want to get a little bit deeper in their knowledge about CPT or ICD-10 or need some bedtime reading?
Yeah, so the Well, ICD-10, I mean, there are some resources out there, mostly by coding groups. KZA has been partnering with the AAOS, and they're kind of the official coding groups. So they do some courses around the country, but frankly, a lot of those courses are really geared towards E&M coding. And I'll say we have had some coding courses geared towards musculoskeletal oncology. We generally do them every 3 years or so. So we'll probably be setting something up over the next year. We have posted some things onto the MSTS website. I think we're going to try to continue to put little tips and primers up onto the website for those that are interested in more of a tidbits that maybe not the everyday stuff of E&M coding, but more on the specifics to our specialty. But KZA does have a lot of really good resources for like outpatient E&M type of coding and the basics of it for more of a generalist audience. I did see a note in the question and answer from Eugene. Eugene Jiang is one of our colleagues who's in the Kaiser system out in California, and they have a very big repository of patients. But they also have the ability, because they're within a closed system, they're not beholden only to the CPT system. So they have basically developed some CPTs of sorts for procedures that don't currently have codes, but we do as orthopedic oncologists, things like rotationplasty or specific for distal femur replacement, for example. So I think that they have about 24 extra codes that don't really exist for the rest of us. And so one of his comments was, how could we leverage this for our society, for our members, for coding purposes? It's a little bit challenging because there are some limitations on both, as we said, widespread use and data. I think that we have good data on distal femur replacements. I don't think that that's the issue. We probably have enough widespread use, but there are some challenges with getting some of these codes like into the code set, or why we haven't necessarily pushed for it from that standpoint. I know it's a point of contention for orthopedic oncologists because, of course, we want to get valued for that work, but there is some risk to it. So to get to Eugene's question, which is, how can we use this repository of these extra codes? I think that the best thing for us would be if we were to leverage that information to say, how are these being reimbursed? How are these being coded overall? And what would anyone else that's going to be doing this as an unlisted, for an unlisted code, what would anyone else expect to get paid? Or what should they be charging for that service if it doesn't have a CPT code? Now, the next thing is that if CMS ever attempts to challenge one of the codes and say it's potentially misvalued, what do we do then? And then we could use this to try to preserve the valuation of the codes. Frankly, the CMS is not looking to come after the orthopedic oncologists or the surgical oncologists. We're in a pretty protected. The House of Orthopaedics is under siege entirely by the RUC and CMS in particular, but we are not, as orthopedic oncologists, quite to the same degree. So no one's really coming after our codes. Frankly, we don't do enough of them to even warrant being on their radar screen. But if we were ever to survey one of these codes, we could take that data in addition to our survey data to try to leverage it for our best interests if it suits our needs. So hopefully that answers that question. We do sometimes get the question of, why do we not have a distal femur replacement code? I get that a lot. It's complicated. But the truth is that if we were to ask for a new code for something like a distal femur replacement, whenever you survey a code, all of the rest of the codes in that family are up for resurvey as well. And so while our primary arthroplasty codes have been under siege time and time again, our revision codes have not been. And our revision codes actually have relatively reasonable valuation. Revision total knee is like 26 and a half work RVUs. So if you're saying, well, we're doing a distal femur resection, our primary code's going to be the distal femur resection. That's going to get you about 31.4 RVUs, more or less. Then you have your primary total knee with a 22 modifier at 19 and change at half value because it's the secondary code. When you look at the risk and benefit to us, even us, not even the rest of orthopedics, just to us as orthopedic oncologists, we probably have more to lose by opening up the revision codes to resurvey than we have to gain by getting our secondary code for that procedure increased value. And that's kind of a long answer to it, but that's some of the mechanics of how the CCRC, the Coding Coverage and Reimbursement Committee, when we look at things like this, say, what is our best play? We thought about it when total hips and total knees and total shoulders came up for resurvey this past year. We thought about, do we want to use this if we're going to get resurveyed anyway, but we still wanted to protect our revision codes because we probably would lose money at the end of the year. So.
Great.
Yeah.
Thanks.
So I also saw there's another question about, I guess for Jordan, the efficiency adjustment created quite a stir in the medical community. It really seems to offset all the gains that we saw in the conversion factor given to us by Congress, and there was a lot of advocacy efforts against that. And so, what do you think the odds are that HR 7520 Efficiency Adjustment Delay Act will actually be successful? Is there a chance that this will really be delayed? I know a lot of us are worried about this.
Yeah, so unfortunately, things have gotten very complicated in Washington on this issue because of budget neutrality. So, as Dr. Levin explained, budget neutrality means that you basically only have a set pot of money that you can spend on the physician fee schedule and on outpatient services. So within the physician fee schedule, everything has to balance out. So if you take from some, you give to someone else. And in this case, the negative 2.5% efficiency adjustment to non-time-based codes resulted in extra money that became a 0.49% bump overall to the conversion factor. So everybody gets that bump, including the primary care and cognitive specialists. And when we say cognitive specialists, we mean like neurologists, for example, cardiologists. They tend to do, well, cardiology kind of splits, but neurologist is a great example because they tend to do a lot of E&M. They tend to do a lot of diagnostics. So they are also more E&M dependent. That 0.49% became a straight up boost to primary care and cognitive because they didn't get cut underneath. Whereas we got cut by negative 2.5% and then got that 0.49% increase in the conversion factor. They did not take a cut. They just got a straight up bump. So if you delay the efficiency adjustment without doing anything else, that bumped the conversion factor that's now built into the scoring baseline goes away and becomes a cut to everyone, but especially to primary care and cognitive. So in our legislation, we tried to address that by stating that we're just delayed and we are not doing budget neutrality. We're basically giving that 0.49% as a freebie and just increasing the baseline. So that costs a significant amount of money, which then makes it harder to pass the legislation because fiscal hawks get concerned when you start spending too much money in Medicare, which is also why it's been so difficult to tie the conversion factor to MEI, because that is a crazy important but crazy expensive proposition that is very hard to pay for. So we're getting caught up in these dynamics of robbing Peter to pay Paul, and then the different dynamics on the Hill. And also in the administration, there's a tremendous amount of sympathy towards primary care, layered in with this belief, particularly coming from the administration, that the rock is corrupt, that it shouldn't exist, that the valuations are all inflated. So when all of these things come together, it creates a very difficult environment for us to explain. And we are trying our hardest for sure that there's no efficiencies, that these cuts are just cuts, and that you still need proceduralists. Like the whole idea of the Make America Healthy Again movement that this administration has come on to tout is lifestyle change. It's improving chronic conditions. But you can't do that overnight, and you can't do that just by paying primary care more. And until we make these wholesale changes and they take years and years to go into effect, seniors are still going to need their knees replaced. You all are still going to be treating patients of all ages with these very rare cancers, and you deserve to get paid for doing that work. And if you don't, depending on how things compound, could be sooner, could be later, you will start seeing access issues, and you will see the MSK physicians unable to keep their private practices. So all the dominoes just have to fall in certain ways. We are trying really, really hard to get the legislation passed. Equally important, as I noted earlier, we're trying to build our co-sponsorship numbers to put pressure on the administration to make some changes at the regulatory level in the annual rulemaking cycle to ease the pain and to go back and just be a little bit more thoughtful and intentional about the policy, particularly in light of the ACS study showing that the entire premise of efficiency is just not true. So we're working really hard through a lot of different angles. But getting the legislation passed is not necessarily the only way to get a delay and not the only end goal that is productive. So we are working all of our channels.
That is complicated. That's a good answer. I guess similar to that is who holds the ultimate power in these regulatory issues? You know, if there's a proposed rule, there's a period where comments can be solicited or accepted from societies. But it seems like when CMS passes a rule, it seems unlikely that they're going to address the rule after the fact, and you have to go after it from the legislative side. And I guess Congress can then either delay or change or repeal or replace the rule with new regulation. But if something like that happens, does CMS have recourse? Does Congress hold the final power? Who owns the final power for issues like this?
So all three branches have a say. The regulators go through the administrative procedures process, which is proposal, receive and respond to comments, finalize the rule. Once it's finalized, there's a couple of options. So in the next rulemaking cycle, or in between if necessary, but you don't see that super often, the regulators can go back and make more changes. They can propose another rule to amend an existing rule, go through the comment process again, and make changes either on or off cycle. Our cycles are yearly, they are statutorily mandated. So most of what we see goes through those annual cycles because you can't do things much faster than that anyways. Congress also has the option to get involved through the Congressional Review Act. There is a number of legislative days within that window that Congress can pass with a simple majority in each house a resolution objecting to a rule. If it passes both houses and gets signed by the president, then the rule is vacated and the agency has to go back to the drawing board. You also have the courts. So someone with standing can file a lawsuit, the courts then rule, and depending on how the courts rule, that also can force the agencies to make changes. And that's what you saw with the No Surprises Act, is just a series of lawsuits that the providers were winning. And each time they won, the agency had to go back and do another rulemaking cycle based on the court's demands. And then occasionally you'll see congressional review acts pass. They tend to only pass one house or the other. But sometimes, every once in a while, they will pass both the House and the Senate and get signed by the president. So there's a lot of different avenues. Some are faster than others, some are more comprehensive than others, but nothing's ever totally done. There are always options to make changes, and that's why we advocate. That's why we do what we do, is to make changes, often teeny tiny, but often very high impact, particularly with physician payments. Oh, you're on mute, Dr. Homlar.
Sorry, I see we're running kind of close on time. One other question maybe, or did you see any other ones, Susan, that you wanted? I did see one across. I think, how do you guys, both of you, Adam and Jordan, how do you see the removal of all the musculoskeletal CPT codes off the inpatient list over the next 3 years playing out? Theoretically, this allows a physician to judge the correct site of service, but we all suspect, kind of similar to total joints over the past decade or so, that insurance companies will then expect those procedures to be done as outpatient, require additional documentation to approve any inpatient stay, and kind of overall reimbursement will decrease over time. Do you think that this will overall be a net good or a net bad for us in orthopedics and orthopedics oncology? A lot of our codes have the same code, like total knee, but for more complex procedures. How do you think this is going to play out?
I take a skeptical view on just about everything, Kelly. So I think that it ultimately people are going to find a way to hurt us. I think it really comes down to how does the prior authorization process work out. Much of things, as they've gotten more automated, even my experience is, even if it's not automated, it's someone sitting in front of a computer putting in the exact same non-automated information into a computer system and reading out an algorithmic approach, which doesn't necessarily reflect our complexity of our practice. I'm hopeful as AI gets integrated into it that perhaps some of that complexity can get brought into it. And allow some flexibility. But in the short term, I anticipate some growing pains. And that's part of why I think those patient stories and our physician stories are going to be really, really powerful to help explain where, while we may be a rare outlier even within the house of orthopedics, those outliers are really important. And frankly, I don't think any of them resonate the way that ours and some of the complex pediatric stuff, the neuromuscular patients, those are the ones that really resonate with the public and with those on Capitol Hill. And I'm hopeful that when we put in the legwork early on to go and say, this is really hurting people, like real people, that will allow some of those flexibilities to be extended going forward.
Absolutely. All right. I think we've extended past our time, but thank you guys so much. Thank you to our speakers. Thanks for everybody who's attended. I think we as a society can educate ourselves and become more involved in the process. And so thank you all. Have a great night. We'll see you for the next webinar.